Dear student, welcome you all to today's lecture. Today our topic is OSPE. This is a very important station for your final professional examination. It will help in a separate day, and there are 10 stations in OSPE. Allocated time is 3 minutes in each station, and allocated number is 6 in each station, and total marks is 60. In general surgery, this is the slide shows the 10 station and is produced by university. The 10 station, the one station is plain X-ray, another station is contrast X-ray, and another station is orthopedics X-ray, another station is specimen, instrument station 1, appliance like catheter, tube, stoma, and reservoir bag 1 station, data interpretation, there's some problem oriented data at 1 station, and procedural station is 2 station. There is clubbing, gowning, knotting, etc. And another station is split or bandage is 1 station. These are the total 10 stations in your professional exam. I already mentioned the allocated time is 3 minutes and the number allocated is 6 in each station, and total 10 station, total marks is 60. Today we will discuss about the plain X-ray, that means station 1. There are some principles to write answer in OSPE. In OSPE, you will make answer in a word, not in a sentence. You will try to make answer in short. You will try to make answer in a word, and you will try to answer in specifically, not elaborate the whole things because the time is limited, and also careful about the specific answer because there is a checklist on the answer. If you not write the common things or important things, then you will not get the marks. So be careful about answer, and it will better to take separate preparation to score a good number. So today we will discuss about the plain X-ray. There are some X-ray can be in your exam. So we will discuss about this X-ray. First of all, I want to mention the X-ray that's showing on the screen. Sometimes there may be a scenario in the top of the X-ray. There is some scenario that help you to identify the X-ray, and sometimes may not present this type of scenario. If you look that a 30 years may present with severe abdominal pain, this is the X-ray of this patient. Please read carefully and answer the following question. In your OSPE station, there may be some clue in your scenario that will help to answer the question easily. If you look at this X-ray, what will we see? This is an chest X-ray. This is a chest X-ray showing the trachea that is centrally, the heart shadow, the lung shadow, and if you look at this area, this is the liver dome. Sorry, this is the diaphragm, and this is also the diaphragm. and there is a crescentic gas shadow. This is the liver border. So there is a crescentic shadow in both dome of the diaphragm. The crescentic shadow in the left dome of diaphragm is normal due to fundic gas, but the crescentic gas shadow in the right dome of the diaphragm is not normal. It is an abnormal. So the question may be like that way. Describe the X-ray. What is your diagnosis? What are the cause of this cessation? What are the cardinal feature of this cessation? How will you resuscitate the patient? What are the stages of generalized peritonitis? What is the treatment option? The question may be like that way, maybe a 3 question, maybe a 6 question. If there is a 3 question, then this question may carry 2 marks. Sometimes one question may carry 1 mark, another question may carry 3 marks or 4 marks, like that way. This is the example of question may found in your exam. So describe the X-ray. How will you describe? The X-ray chest showing crescentic gas shadow both dome of the diaphragm. This is the description, not elaborate like a trachea centrally placed. There is a liver shadow, lung shadow, not like that way in OSPE. But in if it is present in previously in our exam, it will in Viva board, then it will describe like that way. But in OSPE, you will just mention the crescentic gas shadow. The X-ray says showing the crescentic gas shadow both dome of the diaphragm. The next question may be, what is your diagnosis? Diagnosis is pneumoperitoneum. Then the next question may be like that way, what is the cause of this cessation? What are the cause of this cessation? That is the pneumoperitoneum. What are the cause of pneumoperitoneum? The cause is like that way. Do not mention the all things, but I will mention the all things for your understanding the procedure. So, what are the cause? Perforation of hollow viscera containing gas. What are the hollow viscera? Hollow viscera may be total GI tract, the hollow viscera. The most common perforation we see in our surgical ward is duodenal ulcer perforation. And the another perforation is the gastric ulcer perforation. And another one is gastric cancer perforation. Another one is the penetrating injury abdomen due to main homicidal or accidental. Lung trauma also produce perforation, and also Bulletinjury produce perforation. And in typhoid ulcer may also perforate the ileum, but in all cases not present the gas shadow. 70% is patient present with this crescentic type of gas shadow. Usually the ileal perforation not present with the gas shadow because the perforation is usually small and not produce so much gas to gas that retained in the under the diaphragm. And another cause is that is not pathological following laparoscopy or laparotomy. If you do a laparoscopy and laparotomy, following laparoscopy and laparotomy, there is a gas shadow under the right dome of the diaphragm, but it is if gas reduce take time to 5 to 7 days. But before 5 to 7 days, if you do a chest X-ray, you may found a gas shadow under the right dome of the diaphragm, and not worried about this. That because it is the physiological phenomena. So another importance in gynecologist, following tubal insufflation is also produce gas shadow under the right dome of the diaphragm. So what are the cardinal feature of this cessation? The cardinal feature, you like in your exam, you may mention some cardinal feature like 3 common clinical feature. Write down the 3 common clinical feature of this situation, but I will mention the elaborately for understanding of you. The abdominal pain. Usually, the severe abdominal pain works on movement. That works on movement. The difference between intestinal obstruction pain and the perforation pain is that in case of perforation, the pain is works on movement, but and that's why patient restrict his movement, his bed bound and not move to not move. But in case of colicky pain, in case of intestinal pain, patient is moved around his bed. So if you find out, if you look at this patient, then you can find out whether it is the perforation or it is the intestinal aortion. You the patient gives you some clue, and the tenderness, muscle guard, rigidity, rebound, tenderness of the abdominal wall. Look at the guarding and rigidity. There are two different things. Guarding means the voluntary thing and rigidity is involuntary. Rigidity is the definitive sign of peritonitis. Rigidity is involuntary. When patient feel pain in the abdomen, if you examine the abdomen, patient may guard the abdomen, may resist, may make heart of the abdomen, but it is not a feature of peritonitis. But if involuntary, you divert, if you can divert the patient concentration, and if you press the hand on the abdomen, if there is a rigidity on the abdomen, then you say that the pain is due to rigidity. So the guarding and rigidity differentiate you whether patient pain is due to peritonitis or not. The another importance feature is absence or reduced bowel sound. Later stage or in late stage of the perforation, patient bowel sound is absent. The absent bowel sound is one of the clinical feature of the generalized peritonitis. And obliteration of liver dullness. This is also an important clinical findings in generalized peritonitis. Also, may patient present with septic shock, and another other clinical feature may also present. But these are the most important findings of the generalized peritonitis of a patient. How you resuscitate the patient? How you resuscitate? You not mention all the things, but you put the answer in speedy way and try to make all the things in a short answering way. Like correction of fluid loss and volume, circulating volume, urinary catheterization, gastrointestinal decompression must. Antibiotic therapy, anti-ulcerant analgesia, but must avoid the NSI and especially treatment of the cause. If you mention this lightweight, you will get the full marks. But every time you should keep in mind that you must answer in the rapid way and cover the whole things. What are the stages of generalized peritonitis? Maybe the question may like that way. I mentioned here is the stage 1, 2, 3. But if the question is like that way, then you not mention the stage 1, 2, 3. You just mention the stage of chemical peritonitis, stage of ileation, stage of bacterial peritonitis. After perforation, there is a food material, the intestinal contents enter into the peritoneum and produce a chemical peritonitis. And due to these foreign particles or due to gastric content in the peritoneum, there is irritation of the peritoneum, produce severe secretion in the peritoneum, and patients have relief of the pain, and that is called stage of ileation. Usually 2 to 4 hours after chemical peritonitis, patient sometimes feel better. And after that, the translocation of the bacteria, gut bacteria, and produce a definitive bacterial peritonitis. These are the 3 stages of generalized peritonitis. So I will show you a picture of a terminal stage of generalized peritonitis. another X-ray, I will show you that like that way this X-ray. But you, if you look at this X-ray carefully, what you found that X-ray is that there is a distended bowel loop, multiple air fluid level, and it is a step-ladder pattern, and the loop is present in the centrally. And if you look carefully, there is an ecogenic, there is a whole guard around the transection whole guard. There is a fold. This is the volvula condimentis. This is nothing but mucosal fold. More proximal the obstruction, more number of the volvula condimentis. And this volvula condimentis is the whole of the guard. If you look carefully there, this present in whole of the guard, and it will differentiate the large intestinal obstruction. So if you found that a X-ray like that way in your exam, a question may be like that way. Describe the X-ray. What is your diagnosis? What are the cause of the cessation? What are the cardinal feature of the cessation? How will you resuscitate the patient? What is the treatment? How many fluid levels regarded as normal? What is strangulation? What are the features suggest strangulation? So describe the X-ray. Describe the X-ray. There is a plain X-ray abdomen showing multiple gas distended bowel loop with multiple air fluid level and volvula condimentis. That is also the distended loop are in step-ladder pattern and present in the central. These are the difference between large intestinal obstruction and small intestinal obstruction. In large intestinal obstruction, the distended bowel loop present in the peripherally, and it is not in step-ladder pattern, not the volvula condimentis that is in the large intestine called osta. This is not in complete manner like that way. So this is if the question is what is your diagnosis? If you answer that small intestinal obstruction, you will get the full marks. But if you say that intestinal obstruction, you will get marks. But here clearly shown that the distended bowel loop is centrally placed, and also the volvula condimentis and step-ladder pattern. That is the typical feature of small intestinal obstruction. So you, if you write that it is a small intestinal obstruction, you will get the full marks. So what is your diagnosis? What is the cause of this cessation? What are the cause of intestinal obstruction? I will mention the elaborately for your understanding that the cause of intestinal obstruction outside the wall may be hernia, may be adhesion, may be volvulus, may be due to intussusception. But in the wall, that is the tubercular stricture, Crohn's disease, malignancy, in the lumen, gallstone, roundworm, insipid feces, and meconium ileus. But in your OSPE exam, it will not elaborate like that way. You must put your answer in the common things like adhesion, obstructed inguinal hernia, volvulus, intussusception. Sometimes you may show that three common cause of intestinal obstruction. You mention like that way, adhesion, hernia, volvulus, intussusception. If you write that meconium ileus, insipid fissure, roundworm, gallstone, if you write these four things, you may not get any marks. It is right. It is right that this is the cause of the intestinal obstruction. You right, your answer is right, but you will not get even any marks because in your checklist show there is the common things in the checklist like that are adhesion, hernia, volvulus, intussusception. So you must answer like that way the most common things and most important things. Not write like that way. So what is the cardinal feature of intestinal obstruction? Intestinal obstruction cardinal feature is vomiting, pain, distension, and absolute constipation. More proximal the obstruction, more common symptom is vomiting, pain. More distal the obstruction, more common symptom is constipation and distension. So, in case of a small intestinal obstruction, more common feature is vomiting and pain. And in case of large intestinal obstruction, more common feature is distension and absolute constipation. So I am going to the question session. Then, what is the how will you resuscitate the patient? The resuscitation is like as perforation, like correction of the fluid and electrolyte, anti-suction, catheterization, and proper antibiotic, analgesics, like that. So what is the treatment? Treatment is two types. Sometimes some intestinal obstruction, that is functional or adynamic obstruction, correction of the cause will improve the condition. So you mention like that conservative, and sometimes the obstruction may require surgical intervention. So you write at that way that conservative and surgical. This is the two options of the treatment. So you will get the full marks. How many fluid level regarded as normal? How many fluid level regarded as normal? There is multiple fluid level in this X-ray, and normal fluid level, highest fluid level is 3. One is fundic, and another is duodenal cap, and another is the terminal ileum. So the three fluid level you may found in abdominal X-ray regarded as normal. What is strangulation? This is an important thing. Is what is strangulation? When there is impairment of the blood supply, then it is called strangulation. The obstruction, when proceed to strangulation, there is no scope of delay to intervene the patient for surgical procedure. When the patient obstruction is colic in nature, but clinically how will you differentiate the strangulation and obstruction? In case of strangulation, the patient, when blood supply impaired, the pain, which is initially colic in nature, become continuous in nature. So when you found that the patient colic pain cease and it become continuous, then you suspect it is due to strangulation, and early intervention, immediate intervention is necessary at this point. Otherwise, there may be a gangrene of the gut. What is the feature? This is the feature of the strangulation. So, what is strangulation? When the impairment of the blood supply occurs, that is strangulation. What is the features of strangulation? When the colic pain become continuous, then we suggest that is gut become strangulated. Another X-ray, if you read this X-ray carefully, that is the gas distended bowel loop. Before I go through this X-ray, I will show you some another picture. This is the picture of the large intestine. This is the picture of large intestine. There is a cecum, ascending colon, transverse colon, descending colon, and this is the sigmoid colon, rectum. Look at this point of the sigmoid colon. This is the mobile part of the large intestine. More or less, this is the fixed large gut, not look like that of a small intestine, but the sigmoid colon, it is the mobile part of the large intestine. So in case of another picture, this is the mobile part. This is the mobile part of the intestine and move around. And this is the small intestine. This is the mobile part. But in case of the large intestine, the sigmoid colon is the mobile part of the large gut. So in this mobile part, there is some predisposing factor of this mobile part of the sigmoid colon. There may be some band of adhesion. There may be some overloaded colon. The pelvic mesocolon is the long pelvic mesocolon, and there is a narrow attachment of the mesocolon. That's why it becomes twisted. It becomes twisted. So it is more prone to twisted. So if it is prone to twisted, so what happens? If you look at this picture, this is the twisted sigmoid colon. If they twisted, then what happens? If there is a twisting, then initially the venous return is impaired, and after that there is an edema, congestion, and uh, for that reason, uh, blood supply of the artery also impaired, and patient may present with feature of intestinal obstruction. Feature of intestinal obstruction. So it more become more prone to develop large gut obstruction, and that is called the volvulus. So volvulus is one of the most common large intestinal obstruction. So we go to the first slide. So this is the volvulus. This is the typical feature of volvulus. Previously, it is shown that the pneumatic tire light, or in case of if you do an contrast X-ray, it looks like a bird beak. So this is the typical feature of the volvulus. You look at this picture. This is the one border. This is the another border. These are the three borders. Actually, this is the whole sigmoid colon. The middle border becomes one. So the question may be like that: describe the X-ray. This is the huge gas distended bowel loop. Use gas distended bowel loop like a pneumatic tire light. What is your diagnosis? If you answer like that way, the large intestinal obstruction is also correct. If you want to get full marks, you can also mention this is the volvulus of the sigmoid colon. Another site of the volvulus, the most common site of volvulus is in sigmoid colon. So what are the predisposing factors of this situation? I already mentioned this. This is the factor, the band of adhesion, the overloaded pelvic floor, the long pelvic mesocolon, and narrow attachment of the mesocolon. So this is the predisposing factor that predispose to rotate or twisted the colon. Maybe the most common is anticlockwise. So this is the predisposing factor of the volvulus is the band of adhesion, elongated pelvic floor, long pelvic mesocolon, and narrow attachment of the pelvic mesocolon. So what is volvulus? What are the cardinal feature of this situation? Cardinal feature is the same. But you mention like abdominal distension, constipation, pain, and lastly, usually vomiting is late feature. Vomiting is the late feature. So in case of large intestinal obstruction, we mention like that way. The cardinal feature is the distension, absolute constipation, pain, and vomiting. But in case of small intestine, like that way, vomiting, pain, abdominal distension, and absolute constipation. So you must remember these things, whether the obstruction is a small intestine or it is in the large intestine. So what is volvulus? Volvulus means axial rotation of the colon along is mesentery. Along is mesentery. What is compound volvulus? Another term is compound volvulus is also called ileocecal knotting. That is, if you look at this picture, what will happen? This is the sigmoid colon, why I say this is the appendices circulate the ostal fold. So, and this is the ileum. If you look at this picture, then a sigmoid clone and ileal clone, it may become rotate around each other. The ileum also may rotate around the sigmoid clone, and also the sigmoid clone around the ileum. So if this ileum is around the sigmoid clone produce the volvulus, this is called compound volvulus. And if it is happen, then the cecum may be gangrenous or ileum may be gangrenous or both may be gangrenous. This is called compound volvulus. So what are the cause of larger obstruction? This is another way you can mention that outside the lumen like volvulus into suspension in the mural intramural like an carcinoma rectum, Crohn's disease, tuberculosis, and another way outside the lumen is like that volvulus. So how will you resuscitate the patient? Is the same way of the resuscitation, like fluid and electrolyte correction, IV fluid, analgesia, antibiotic, antisection, and catheterization. And what is the treatment? It is very difficult to say in one answer in treatment. The treatment you may mention in your OSPE like that way, treatment, conservative treatment and surgical treatment according to findings. This is the very simple way that covers the whole thing. And already mentioned the practice of strangulation, congestion at the site of obstruction, initially venous return is impaired, congestion, edema of the bowel wall occurs which turn purple, and later this jeopardize the arterial supply and produce strangulation. Another X-ray showing this is. You may also found that there is a scenario like that where 30 years male patient with right loin pain. This is the X-ray of this patient. Please read carefully, answer the following question. You may have some clue in your exam. So if we see there is a radiopac shadow in the right side and there is a radiopac shadow in the left side. That if there is a radiopac shadow on the right side, what may be the DT, what may be the cause, and if you see a radiopac shadow in the left side, it is easy to diagnose more than the radiopac shadow if you found in the right side, because in this region the 10% of the gallstone may be radiopac, so you cannot differentiate by a single X-ray whether it is renal stone or whether it is gallstone. But in this picture, we say that it is a look like an stag horn, so you can assume that it is renal stone. But when there is a single radiopac shadow in the right side in a single X-ray, it is difficult to whether it is renal stone, gallstone, radiopac gallstone, or pancreatic stone. And and another, there are lot of differential diagnosis in the radiopac shadow in the right side. I will mention later on. So this is the plain X-ray kidney and urinary region showing a radiopac shadow, and better if there is a full X-ray like that way, you mention the vertebra level. Like that, I said, this is the fifth vertebra, this is the fourth, this is the third, and this is the second, at the level of second vertebra. This way is very authentic way to mention the height of the way according to the vertebral level by counting the vertebra. If X-ray showing like that, the whole X-ray, if you count the vertebral level, then that is the better way to describe the X-ray in relation to the vertebra. So question may be like that way. Describe the X-ray. I already mentioned how will you describe this X-ray. What is your diagnosis? What is your diagnosis? It is very difficult to single word. What is your diagnosis? But you mentioned that it may be a renal stone, or if you may mention the renal stone, gallstone, pancreatic stone. You may mention the three of these. How will you confirm? This is the very common question. How will you confirm this X-ray? So, how will you confirm whether it is renal stone? So you confirm by this way, like you do an ultrasound. Ultrasound can differentiate you whether it is uh, uh, whether it is a renal stone or gallstone. As the ultrasound is very available nowadays, but another way, if you have no ultrasound facility, you can do another X-ray of lateral view. Can you ensure this way. If you look at this X-ray, what happens? If you look at this X-ray, that this radiopaque shadow is behind the vertebral column, and so if there is radiopaque shadow behind the vertebral column, then it is the renal stone. If it is in front of the vertebral column, then it is the radiopaque gallstone. This is another way of differentiate uh, the renal stone with the radiopaque gallstone. So the answer may be ultrasonogram is the first, second is X-ray lateral view, like that one. So what are the cause of radiopaque shadow in this region? Actually, right side, there are so many causes like that way, the kidney, stone, gallstone, pancreatic, calculi, foreign body, picolit, levolit, calcified lymph node, calcified renal tuberculosis, calcified adrenal gland, cheek fracture of tempus, process of vertebra, or calcified coastal cut. Maybe directly you may the question maybe not directly what is your diagnosis, maybe the what is your differential diagnosis. Name three or four or five differential diagnosis of the radiopaque shadow in this region. You mentioned like that kidney stone, gallstone, pancreatic stone, or foreign body circulation. Any of the three, five you mentioned in your OSPE, it will get full marks. So which type of stone or radiopaque? Actually, the five type of stone in the renal stone. So four are the radiopaque, oxalate, phosphate, and cysteine and xanthine stone, and the uric acid or uric stone is the radiolucent stone. So the next question may be like that: how the patient with renal stone present, maybe asymptomatic, maybe symptomatic, fixed renal pain, renal or uterine colic, nausea, vomiting, hematuria, pyorrhea, and feature of recurrent UTI. So asymptomatic, when asymptomatic, usually phosphate stain is usually because the surface is smooth and it may become large like an strap horn to cover the whole calyceal system. That's why it become large and asymptomatic. So it may be asymptomatic, maybe symptomatic. Usually oxalate stone presentation is early because it have a spiky surface and produce hematuria, pain. That's why patient present to doctor is early. So fixed renal pain when it is in the renal region, the kidney region, then it is fixed dull aching pain. But when it is lost into the ureter, it produces colicky pain because uterus have smooth muscles that produce colicky in nature, and that's why when the stone become lost in the ureter, it are not in dull aching, it become the colicky pain. And the any abdominal symptom may produce nausea and vomiting, also hematuria to erode the wall, and also pyorrhea and feature of the recurrent UTI. So what other investigation you suggest? Urine, routine microscopic examination and culture sensitivity, serum creatinine, ultrasonogram of whole abdomen and intravenous urography. What is the importance of IVU? Importance of IVU is to see the functional status of both kidney and also to see the exact site of the stone. So I'll go through the question session. So describe the X-ray already mentioned, diagnosis, confirm, how patient present, and what are the investigation we suggest, and what is the importance of it. This is the question maybe like that way, and we will answer will be like that way. I already mentioned. So another X-ray you may found in your exam. A 25 years male presented with recurrent attack of abdominal pain with diabetes mellitus. This is the plain X of the patient. Read and answer the following question. Look at this the scenario. Recurrent abdominal pain with diabetes mellitus. You must in your keep in your mind the feature of the scenario is important. So abdominal pain with diabetes mellitus, what are the relationship this radio effect shadow? There is some relationship have, so that we can hear you. So what is the radio effect shadow? So if the what is if describe, if the question is describe the X-ray, plain X-ray abdomen, but here you cannot mention the exact vertebral level. But if there is a long X-ray, if you mention the vertebral, you want, if you mention the vertebral level, if possible, then you should mention the level of the vertebra. So multiple radio effect shadow along the transverse section in the region of it. There is an both side of the vertebra. Multiple radio shadow both side of the vertebra. So what may be the region? So it is maybe region of the pancreatic calculi or bilateral. What is the differential diagnosis? Bilateral. Renal calculi also may be the right region and left region. So one of the important differential diagnosis in this radio effect shadow in both sides of the vertebra is pancreatic calculi and bilateral renal calculi. So describe the X-ray. What is your diagnosis? How patient present? What are the other investigations and what are the treatment options? So how patient present? So in case of pancreatic stone, why you say pancreatic fast? Because the chronic pancreatitis produce this radio effect shadow, and patient usually present with diabetes mellitus. In chronic long-standing case, patient develop diabetes. So this is the clue that this is pancreatic stone, but there is no relation of the diabetes mellitus with the renal stone. So you must mention the first this is the pancreatic stone. So how patient present? Usually the chronic pancreatitis is a very morbid condition. This is a very morbid situation of the patient. Patient severe pain, non-stop pain, continuous pain, and morbidity is so high. Even she relief from this daily work, and it is very difficult to manage both medically and surgically. So the patient pain may be dull and numb. That is the continuous discomfort with the abdomen. Even this patient due to pain and others, these are patient had history of weight loss, analgesic abuse, steatorrhea due to loss of the exocrine function. Patient develop steatorrhea affecting to the stool in the defecation of the stool, and also patient having a picture of the diabetes and picture of complication. There are so many complications of the chronic pancreatitis like pseudopancreatic cyst and others complication. So if you mention like that, upper abdominal pain, diet, dull and continuous in nature, weight loss, analgesic abuse, steatorrhea, diabetes, viscera. In your exam, you mentioned that three clinical feature of the of such condition. You write this. What is the other investigation you suggest like that serum awareness, blood sugar, MRCP, RCP? It's very difficult condition. So you may mention like one or two or three investigation like that. So what are the treatment options? Treatment option is two, medical and surgical. Medical treatment is treat the addiction. Treat the addiction. Sometimes the patient is alcoholic. Uh, in case of to give the psychological therapy, elevate the abdominal pain, stabilizer pattern. Sometimes the pain cannot relieve, and stabilizer pattern uh, way to relieve the pain, nutritional clearance measure because patient have malnutrition due to exuberant loss of function and also treat the diabetes if patient develop diabetes and surgical. But when you do surgical, there are two indication of surgery. One is intractable pain and another one is development of complication. If two things are happening, then the option is surgical option. So the next X-ray showing that there is an X-ray. This X-ray is a X-ray test. X-ray test showing multiple look cannonball or point shape shadow in both lung feet. Multiple point shape and cannonball shadow in both lung feet. So what is the radiological findings? Multiple point shape or cannonball shadow in the both lung field. What is your radiological diagnosis? Radiological diagnosis secondary metastatic deposit. Why it is secondary deposit? Because in primary lung disease, the usually single in number in primary lung disease, maybe more than one, but not like that several in both lung fields occupying the radioactive point shape or cannonball appearance. So this is the cause of the secondary deposit. What are the primary tumor may give rise of finding? Though lung is one of the most common site of the secondary metastasis, but some tumor have more prone to metastasis to the lung and produce this type of typical feature of the cannonball appearance is the testicular tumor, renal cell carcinoma, soft tissue sarcoma, osteosarcoma, choriocarcinoma, malignant melanoma, thyroid, breast, and prostate. So in case of OSPE, the question may be like that. You mentioned the three primary tumor that metastasis to the lung like that way. So you mentioned this from 2 or 3 or 5. Give 3 to 5 clinical feature. It may be asymptomatic, maybe the feature of lung disease like chest pain, cough, pneumothorax, dyspnea, and feature of primary disease. How can you confirm your diagnosis? You can confirm your diagnosis two ways. One is the image guided FLC, the another one is the bronchoscopy and biopsy. And what are the principle or modality of treatment? Treatment of the primary lesion, treatment of the pulmonary lesion, chemo, radiotherapy, and surgery. So principle of treatment means what? Treatment of the primary lesion. Where is the primary? This is according to the primary. The option may be the surgery or radio, chemo, or palliative. And the another treatment of the pulmonary lesion. Pulmonary lesion is a chemo, radio, and surgery have option if there is a single secondary lesion or multiple lesion confined in the single lobe, then surgery is one of the option. Otherwise, the option is chemo, radio, and palliative. Another X-ray will show you that there is an X-ray kidney universal region, but here is the pelvis region. There is a large radioactive shadow in the pelvis. Large radioactive shadow in the pelvis. So, if the question maybe describe the X-ray. Describe the X-ray like that X-ray of the pelvic region showing a large radioactive shadow on the pelvic region with smooth surface, but it is not so like that this one. what is your diagnosis? Diagnosis is bladder stone. And what are the type of bladder stone? What is the type of bladder stone? Bladder stone is usually two types, primary and another one is secondary. Don't confuse with the primary. Primary bladder stone is arise from the kidney. Though it is the bladder stone, but it arises from the kidney, that is called the primary bladder stone. But when the stone occurs in the within the bladder due to some secondary cause, then it is called the secondary stone. So don't confuse with the secondary stone of the bladder. But the secondary stone of the bladder usually within the bladder due to some secondary cause like that of infection, outlet obstruction, impaired bladder empty, and foreign body. Due to these four cause, when a stone formed within the bladder, then it is called the secondary bladder stone. But primary bladder stone is arise from the kidney. How can patient present? In case of bladder stone, patient present with frequency of maturation, pain or strangulation, that is the severe pain at the end of the maturation. And in case of children, they pull their penis at the end of the maturation, and this is the typical feature of the bladder stone. Patient may present with hematuria, interruption of the urinary stream. Due to bladder stone, may interrupt the urethral outflow. That's why sometimes interruption of the urinary stream may happen, and patient may also present with recurrent urinary infection. So, what is the principle of treatment of the bladder stone? Treatment of the stone and treatment of the cause. This is the principle. Treatment of the stone and treatment of the cause. The cause already I mentioned the secondary cause, that is the infection, outflow obstruction, there may be a BP or any other cause like neurogenic bladder, treatment of the urinary bladder or outflow obstruction, bladder and team, if there is an stricture urethra, may also the stricture urethra or may also other cause, and the foreign body, there may be a foreign body like a written catheter, parts of the written catheter, or any other foreign body, and treatment of this cause also. So what are the option of bladder stone? Option of bladder stone is the lithotripsy. There are many way of lithotripsy, laser and electromagnetic ultrasound, and any other varieties of option of lithotripsy to crack the bladder, to crack the stone and remove paravectomy. And another way of perforating suprapubic lithotripsy. This is an also option if there is a patient with severe stricture urethra and not negotiate through the urethra, then you can include this ultrasound or laser electronic device through the suprapubic root. And another option is suprapubic cystolectomy in case of very large stone. In case of very large stone, this is actually the open method of suprapubic cystolectomy. When there is large stone not captured by the lithotripsy, then is also another option. So these are the 10 X-ray in your exam, and if we have another session, then we will discuss about the other session like contrast X-ray, appliance like catheter, LG2, and like so on. So thank you very much for questions.